FUE Magazine, the authority on hair restoration surgery.
Educate consumers and help educate doctors.
Into the future.
Let's get started.
Hello and welcome to another episode of FUE Magazine, brought to you by FUE Hair Clinic, located in Atlanta and New York City. This is Dr. John Cole, and this broadcast is for both patients and physicians desiring to get more information regarding the treatment of hair loss and the pathology of hair loss. And this episode will deal with Telogen Effluvium, which is one of the causes of hair loss. There are multiple causes, including androgenic alopecia, which most patients present with. And we also can have scarring alopecias, alopecia areata, and other causes. In this episode, we'll discuss Telogen Effluvium. How does it compare to androgenic alopecia? How do we diagnose it? What do we look for? And how do we treat it? So in this episode, I'm going to discuss some of the companies I work with to produce a number of things, including growth factors, PRP, etc. But in this episode, we'll discuss companies Tricolab, Cross-Sectional Trichometry Hair Check, and we'll be using the Derm Light. And this is brought to us by 3Gen. Also, a shout out to the two best societies for educating physicians in follicular unit extraction, the diagnosis and treatment of hair loss of all forms, both medically and surgically, and when to avoid surgery. And these include FUE Europe and the Global Hair Loss Summit. FUE Europe just concluded their 9th annual meeting in Istanbul, Turkey. It was a wonderful in-person meeting of the first meeting in person in a very long time. And we had almost 100 attendees, which was quite interesting because, you know, with COVID, we had restrictions on travel from the U.S., bans basically from the U.K. and from South America, including Brazil, where we have a number of really very interesting surgeons located. So, the hair growth cycle. There are 4 phases: telogen, resting; anagen, active growing; catagen, the transition between telogen and anagen; and exogen, a period when the hair follicle falls out and the cells necessary to produce a new hair follicle are still there, but they're absent. Now, there is a permanent portion of the hair follicle which resides in the first 2 millimeters below the skin, and this is the depth of the dermis. And where the dermis and subcutaneous adipose meet is where we get the impermanent zone into the adipose. The impermanent zone is lost during telogen, and we can see that depicted here with these little blue lines. It's the impermanent zone. It's about 2 millimeters deep. As the hair follicle re-enters anagen, there is an increase in the number of adipocytes, blood vessels, and nerves. There's a definite interaction between the adipocytes and the hair follicles. And then there is a transition from the active growing anagen phase to the catagen phase. And this is a process of apoptosis where the distal part, the follicular streamer or follicular stele, can be seen. This part of the hair follicle will gradually disintegrate as the hair shaft rises into the junction between the dermis and the adipose. And this is the telogen phase, and you will find what we call club hairs here. So this is the hair growth cycle. There are a limited number of cycles on the scalp, and so you can think of it like a cat with 9 lives. And with each cycle, the telomeres shorten, and gradually they're lost. And when you get to the critical number of cycles, the hair follicle stem cells necessary to create a new hair cycle are lost, and we cannot regrow these hairs. So it's very important to catch these hairs before they enter that critical number of cycles because this is the only time you can rescue these hair follicles. The stem cells necessary to initiate a hair follicle are probably influenced by an inflammatory process, in my opinion, that occurs during the telogen phase. So the goal in regenerative medicine is to keep these hair follicles in the active growing phase or anagen phase. So here we can see the hair shaft of a 3-hair follicular unit that contains all anagen hair follicles. They extend into the dermis an average of 4.9 millimeters. I know that Francisco Jimenez published a study suggesting that the depth of the hair follicle average is 4.2 millimeters. This is inaccurate. He preserved the tissue in formalin, and this will result in at least a 10% shrinkage in the tissue. And so he came up with 4.2, but the average is actually 4.9. Now, that does not mean you can't find hair follicles that are 5.1 millimeters all the way up to 6.2 millimeters, and you may see some patients that have hair follicles that are only 3.2 millimeters long. In the anagen phase, the hair shaft has quite a bit of pigment, and it's much darker in color, and extends down into the adipose. So here we can see on the left a follicular unit where we have the catagen phase beginning. We see the beginning of the formation of the club structure here, and that is going to rise up into the junction between the dermis and the subcutaneous adipose. Over here, we see an anagen hair follicle that extends all the way down into the subcutaneous adipose. And over here, we see the follicular streamer or follicular stele, which is disintegrating tissue that was left from the original anagen hair follicle. We see the formation of the club structure here. This is a telogen follicle. So that's all 3 phases that are commonly noted in the hair growth cycle. Now, this is a close-up of the bulb of the follicle. This is the base of the follicle, the bulb. And in the middle here, we see the dermal papilla in this area. And adjacent to that, we're going to see these are the matrix cells. These are actively dividing cells that give rise to the dead hair shaft. So these are active cells, and these become dead. Over here, we see the remnants of the outer root sheath and the inner root sheath. These are both of epidermal origin. And down here, we see the Arrow-Perkins body and the base of the bulb. So that shows you the hair shaft. There's an interaction between this dermal papilla, these matrix cells, and up more distally, the bulge located at about 1.8 to 2 millimeters in depth. That also is an important source of stem cells. All of these interactions allow us to create an actively growing hair. Here we can see a hair shaft that has not been stained and it has not been fluoresced. And down in here is the base of the follicle. This is outer root sheath, the Arrow-Perkins body in here, the dermal papilla here, the matrix about here, and then this is all dead hair shaft with its cortex and medulla. And, you know, you can, how do we initiate a hair growth cycle? Well, in the telogen phase, there is the bulge, and below the bulge is a secondary a secondary germ. That secondary germ is derived from the bulge, so they're both epidermal in origin. With the onset of anagen, the secondary germ will release a protein called anagen, and this will downregulate another protein called bone marrow protein, or BMP. And when you downregulate BMP, the bulge will begin to enter the beta-catenin Wnt pathway, and it will produce proteins that result in the prolongation of that hair follicle down into the subcutaneous adipose. Now, where's the dermal papilla? It's adjacent to the secondary germ, and the dermal papilla is mesodermal in origin. So it's an interaction between epidermal cells and mesodermal cells, and the interaction is multiple proteins that we don't quite understand, which is why hair cloning is so unlikely to occur anytime soon. It's a very complex process involving multiple stem cell populations of different embryological origin. So here we can see a hair follicle that's in anagen. We see another one here that's in telogen. And down here we see the follicular streamer noted by the black arrow. This hair follicle you can see is curved. So hair follicles are not straight, they're curved. And the sebaceous gland is always located on the anterior aspect of that follicle. I call that the belly of the graft, and the other side is the back of the graft. And when you place this graft, you want to place it on its belly. That way the hair will grow along this curve and angle down on the scalp. If you place it on its back, it will angle up. If you angle on its side, it will grow this way or the other side like that. So very important that you place the graft properly. Now, we can see telogen follicles anywhere on the body, and we can also find anagen follicles, and they look somewhat similar. You know, these are off the chest. The ones on the right are from the leg, and we can see the beginning of the catagen phase. So in catagen, the first sign of catagen, the progression to telogen, is a decrease in pigment, a reduction in melanin production. So notice this hair shaft is a little bit lighter than the adjacent hair shaft. Now on the body, anywhere other than the beard, including the neck, you will see about 40 to 60% telogen hair grafts, resting hair shafts. And the growth rate of these telogen hair grafts is not quite as good as the anagen hair grafts. So we always want to choose the anagen hair follicles. And how do we do it? These are darker on anagen side, and they leave a little bit of shadow in the skin, so they're easy to identify. But the best way is to wet shave baby smooth about 3 days prior to surgery. On the beard, almost all the follicles are in anagen. In fact, it's very uncommon to find resting hairs. An example of a scalp hair graft that has all the hairs in telogen. And, you know, there are many academics that don't believe that a scalp hair graft can be all telogen hairs, but it can. Average is about 8% telogen on the scalp, but it can range all the way up to, I've seen it, 26 to 28% in some patients, and to me that's a little concerning. Kligman said it's normal up to 25%. It may be. But to me, it implies the donor area might be less permanent when we see these very high ratios of telogen hairs. We also tend to see telogen hairs, you know, high up on the scalp, high up in the occipital area and lateral scalp, and down around the nape of the neck. That's where, if you want to find telogen hairs, that's where you go. But when you start to see telogen hairs high up in the donor area, it's probably a sign that those follicles are less permanent. Again, this is an example of telogen hair grafts. They're off the scalp. There are 2 hair telogens on the right and 3 hair telogen hair graft on the left. So all of the hairs can be in telogen, but this is not an example of telogen effluvium. In telogen effluvium, you will see an increase in the number of single hair follicular units. And yes, you may have a telogen hair, but you've usually got exogen hairs. Now, causes of telogen effluvium. It usually is some sort of stressor, a major life change, like a breakup in your relationship, or losing your job, the loss of a loved one. And we've seen telogen effluvium in the pandemic related to COVID-19. And, you know, it's not that uncommon. Significant health changes, or having a significant disease like the flu can cause telogen effluvium. Rapid changes in weight, change in your diet, excessive exercise, vegan diets, keto diets, and other things like being in war or a long distance travel. Anything that's stressful can cause telogen effluvium in the scalp. So this is an example of telogen effluvium, and what we can see here is an increase in the number of single hair follicular units. We don't see miniaturization. We do see right here an early anagen follicle. An early anagen follicle will have a very fine tip. It will be much lighter in color at the distal end, and then there will be an increase in pigment toward the base of the follicle. So that is an early anagen follicle. But see these little single hair grafts here that you can see in this red circle and the green circle, and you see this little shadow here, and here, and that's indicative that these are in anagen phase. All right. You see increased number of single hair follicular units in telogen effluvium with a lack of miniaturization. That's your diagnosis. This is a more normal scalp. You see a lot of 2s and 3 hair grafts. You see an early anagen hair follicle here. You don't see a predominance of singles. Okay. This is you see one here, but you don't see a ton of singles. Maybe one here, but it's not mostly singles. And this is another example of where we see an increase in the number of single hair follicular units. This is suggestive of telogen effluvium, but this is in the donor area. And so this is a patient who presented for a hair transplant. And the question is he a good candidate for a hair transplant? Because he also has an increase in the number of telogen hairs. You know, he's up around 22% telogen hairs in his donor area and an increased percentage of single hair follicular units. Now, you will see a lot of FUT surgeons will produce about 20 to 22% single hair follicular units. And how do they do that? They subdivide the natural follicular unit. You know, you average 2.4 hairs per follicular unit in the occipital area and 1.8 hairs per follicular unit on the lateral side of the scalp, 2.1 in the mid-mastoid region. So single hair grafts are actually very difficult to find. In fact, the ratio should never exceed 8%. So if your surgeon is producing 20% single hair grafts, he's doing it by subdividing follicular units. And just remember, 2 hairs will not cover as well as 3, and 1 hair will certainly not cover as well as 2 or 3 hair follicular units, and certainly not as well as a 4 hair follicular unit. So if you want the big bang for your buck, you know, your surgeon needs to know what's in the donor area. And why is it so common for surgeons to have 20, 25% single hair grafts when they perform FUT? Well, it's because the vast majority have never learned the assistant's role. You know, they walked into a clinic and they saw that the doctor removed the strip and the technicians or nurses dissected the grafts, and then they placed the grafts. And they never knew the assistant role. So when I train a surgeon, believe me, when I train one, he's good. He's real good. And the reason is I train him to be an assistant first. And so I train him what the assistant should be producing from a donor area. You know, how an assistant should place a graft. So that surgeon is going to learn to place grafts. And that way, when he goes off to his own clinic, he can evaluate the quality of the work of his assistants and make sure that he's providing the best possible result for his patients. But overwhelmingly, the surgeon does what he thinks is the surgeon's role, and the nurses or technicians do what they think is the technician role. And the surgeon has no idea what makes a surgery optimal and what doesn't. And that's because, you know, as we transition from 50 grafts per session to thousands of grafts per session, we had to involve assistants. But as we did it, we didn't make sure the surgeons knew, you know, how to properly prepare grafts, how to properly place grafts. So another example of a donor area with a lot of natural 1 hair follicular units. This is probably telogen effluvium in this donor area because there are more single hair follicular units, but it also could mean that he's just not a good candidate for a hair transplant, even though the overall follicular unit density is good. And that's what happens in telogen effluvium. You maintain the normal follicular unit density, you have a reduction in the number of hairs, and because there are fewer hairs, the coverage is less, and the patient will complain of thinning. Here we go, an example of Telogen Effluvium. And we see there are more single hair grafts. You still see there's a lot of 3s and 2s and whatnot. This is not a marked or aggressive form of Telogen Effluvium, but this is Telogen Effluvium. And so what we have to do here is stimulate a lot of these follicles that are in the resting phase to get back into the growing phase, and we'll go over how we do that. This is the donor area of that same patient, and you see that we don't see that preponderance of increased single hair follicular units. Most of the hairs are in 2s and 3s, so the donor area is unaffected. We can go back and look at the top of the scalp, and there are a lot more of these little one-hair grafts in here, bing, 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 and there are one-hair follicular units, and that's Telogen Effluvium. Donor area, no, we don't see those single-hair follicular units. What's the difference between androgenic alopecia and Telogen Effluvium? Well, the first sign of androgenic alopecia is a decrease in pigment. So if you look carefully here, you see these colors aren't as darkly pigmented as the hairs in the periphery. These are much darker. And in the center of this crown, we can see that he's got lighter colored hair. Now, this is early androgenic alopecia, so there's been absolutely no loss in hair density or follicular unit density. Okay, so he's still got a normal number of 2s and 3s. He doesn't have a preponderance of 1s. And this is when you want to rescue this scalp with regenerative medicine. This is when they will respond the best. In fact, they'll respond even better if you catch this crown before it gets to this stage. And we'll talk about ways to do that. But when you rescue this scalp, what will happen is the diameter of these hair shafts will increase, and that will produce more coverage. Now, there's been no loss in hair density, but there's been loss in hair diameter. And sprinkled in here, you can see some little darker hairs, and those are even less influenced by the androgenic alopecia process. So these are more likely to respond to regenerative medicine. Catch them early. So what's in the donor area? Over the temporal area or left auricular area, you're going to have about 1.8 hairs per follicular unit, and as you move to the mid-mastoid area, you should average around 2.4 hairs per follicular unit. That's not to say that some people won't have less in the mid-occipital area, and some might average over 3 hairs per follicular unit. And when we look at the number of follicular units, it's usually about 80 over the ear, but down to 60 is not uncommon. And in the mid-occipital area, it could be 80 up to 100 hair follicular units in the mid-occipital area per square centimeter. Mid-mastoid is somewhere in between, so it's a good average. Good place to measure because see if you want to do a single measurement, mid-mastoid is your best area. Diameter is finer in mid-occipital, and it's next in the supraauricular area and coarsest in the mid-mastoid area. So based on that, we can go look at something we call the TrichoLab. And TrichoLab is a great way to evaluate hair loss. Okay, so this is a company that has a device that allows you to take images in the front of the scalp, the temporal area of the scalp, and the occipital region of the scalp. And then you can compare hair numbers. So let's take a look at them. In the frontal area, he has the first example. On the left is 115 hairs, and in the temporal area, 109, and in the occipital area, 152. So there's definitely been a drop-off between the occipital area and the frontal area. And we'd expect those two regions to be roughly the same. It's normal to see a decrease in the temporal area compared to the occipital area, but average would be somewhere up around 120 to 145 in the temporal area and up to 225 to 240 in the mid-occipital area. You might see 210, but up to 245 in the mid-occipital area. And in patients that are really good candidates for hair transplants, it may be closer to 300. So there's definitely been a loss of hair in the frontal area. And so now we want to look at the percentage of hairs that are very fine. And we can see that the very fine hairs, there's not been much of an increase. Hairs over 50 micrometers, and average is about 70 micrometers, but the number is a little bit of a decrease in the frontal area compared to the temporal and occipital area, and we see a little bit of miniaturization between 30 and 50 micrometers in the frontal area. And let's look at the single hair follicular units. Well, that's a high percentage, 54% in the frontal area, and in the temporal area is 41%. You remember I said 8% is about right. And in the occipital area, 22%. So, this is an individual that, because he has a decrease in the number of total hair follicles and he has an increase in the number of single hair follicular units, probably has some telogen effluvium going on. Okay? In the second example, we see a similar number of hairs throughout the scalp. We see that the number of hairs greater than 50 micrometers is 90 to 95%, and those below 50 micrometers are much lower numbers. This is far more suggestive of a diffuse telogen effluvium. Okay, remember, maintenance of the diameter and also an increase in the number of single hair groups. In the left example, there is some evidence of a combination of both telogen effluvium and androgenic alopecia, and they certainly can occur simultaneously. Now, what is another tool we can use to evaluate patients with both androgenic alopecia and telogen effluvium? Well, it's cross-sectional trichometry. This is a hair check device, and what it does is it bundles the hair and allows us to come up with a number. And what I like to do is compare the donor area to the crown, the top, which is between the ears, and the frontal area. And I look for a drop-off. So think of it this way. If you have a box of spaghetti noodles and it has 100 noodles in it, and you have another box that has 100 noodles and they're both the same diameter, when you compress them with the hair check device, you will get a similar surface area, similar compression number. And let's assume on one box you have 100 noodles, and in the other box you have 50 noodles. You'll get a lower number in the 50 noodle compression. So the hair check is a measure of both diameter and number. There's a decrease in number, you'll have a decrease in the hair check number, or cross-sectional trichometry. But you also get a decrease when you reduce the diameter. So you can go from fettuccine noodles, 100 of those, to angel hair pasta, 100 of those, and you'll get a much larger number with the fettuccine noodles. All right? Now, in androgenic alopecia, you can think of it this way. The hair moves from fettuccine noodles to angel hair pasta over a period of time, and eventually when the hair gets to the critical number of cycles, the angel hair pasta goes into the boiling water and it makes spaghetti. Now, how do you make angel hair pasta or fettuccine pasta from spaghetti? It's impossible. So you have to catch those hair follicles when they're somewhere between the fettuccine noodle, the regular spaghetti, or the angel hair pasta to rescue them with regenerative medicine. Don't let it get to where they're spaghetti. You can't make pasta from spaghetti. So what I do is I measure the cross-sectional trichometry in multiple locations. I measure in the front, which here is in number 7. Now, number 7 is not 7 centimeters. It's a distance from the glabella to the front of the scalp, but it's not measured in centimeters. These are arbitrary numbers. They're actually, it's much more than 7 centimeters, and it's more than 10. It's probably closer to 10 to 11 centimeters. At 13 is between the ears in a male. It might be a little less in a female, and 21 is the crown. And in the donor area of a male, I measure around 31 to 32. In a female, because the skull is a little smaller, it might be 28, 29. So these are reference points there. And getting the cross-sectional trichometry at each location allows me to predict hair loss, evaluate the degree of hair loss, and also monitor the response to treatment. For example, I've had women who had androgenic alopecia. I give them good quality PRP, and their 13 might go from a 64 to a 92. Now, what's average? 70. But in androgenic alopecia, you're going to have a reduction in number, but you also have a reduction in number with telogen effluvium. So you can't, by hair check alone, diagnose telogen effluvium. It just means you definitely have hair loss. Now you need to get out your dermoscopy, which is, let's say, your DermLite Pro, which is what I use from 3Gen, and start looking at the scalp in a close-up fashion to see what's there. Is it an increase in the number of single hair groupings with no miniaturization, or is it miniaturization with, let's say, a reduction in the total hair number of follicles up there, which would be advanced androgenic alopecia, or is it a combination of miniaturization and normal hair follicle diameter, which would be early androgenic alopecia? But you won't know necessarily to look for this if you don't have the cross-sectional trichometry. So let's look at an example. In this particular patient at mark 32, which is the donor area, we have a 92. This patient's a great candidate for hair transplant surgery because 92 is well above average. Now, some patients are over 100, maybe 108, 110. They're even better candidates, and it means they either have more hair shafts in their donor area or they have a higher diameter. Hair check or hair cross-sectional trichometry is a measure of number and diameter. Now, let's look at their front. It's a 62. There's a 33% decrease in mass, hair mass, in the frontal area. This individual is not going to exhibit evidence of hair loss with a 62. Average in the donor area is 70. So he's not going to exhibit evidence of hair loss, but he's losing his hair. And if you don't do the cross-sectional trichometry, you're not going to know. In the top, he's an 88, which is very close to a 92. The top doesn't really show evidence of hair loss at this time. What about the crown? It's a 30. This is an individual who's going to have a very thin crown. So, he's got 68% loss back there. Now, the crown is going to show visual evidence of androgenic alopecia or thinning when the hair check is lower. When the hair check is higher. So thinning is more evident with a higher hair check in the crown, and that's because the hair grows in multiple directions, to create the spiral. In the top and the front, hairs tend to shingle in similar directions, and so the shingling effect allows them to display evidence of a full head of hair in the front and the top, when indeed there might be thinning. So in this patient, just looking at his cross-sectional trichometry, I don't need to see a picture of him. I can tell you that he's going to present with isolated vertex loss, but he's also losing his hair in the front. This patient is moving to a 3 vertex. And so right away that a transplant alone is not enough to treat this patient. You're going to have to do some sort of regenerative medicine to hold on to that front. And a full regenerative medicine protocol is advantageous. Okay, now you couldn't say that the front is not telogen effluvium based on this alone. This is when you want to definitely do your dermoscopy. So here's an example. This particular patient has a cross-sectional trichometry of 94, well above average. A good candidate for a hair transplant. In the crown, he has lost 87% hair mass. And you can see that it's thin crown, even though it's had 1,737 grafts. It used to be bald. but he's still thin. You need more grafts here to make this patient look full. So crowns are the hardest place on the scalp to finish. They're harder to finish with a single pass. You can usually get the front and the top with a single pass unless they have very fine hair or low density low calculated densities where there are fewer hairs per follicular units. Now look at his front, 76% loss. His top, 64% loss. But he looks full. He looks full. But I can tell you right now, this patient is going to a Norwood Class 5. Even though he has a very good hair check number in the donor area, he's less optimal candidate for a hair transplant because he's going to a Norwood 5. 150 to 180 square centimeters of hair loss. Traditional safe donor area is 203 square centimeters. You can expand it to about 230, 240 square centimeters. But unless you add body hair, it's going to be a hard job to finish this guy off. Now, some patients have really outstanding donor areas, what I call home run hair. And, you can get them closer to the appearance of a full look, than you can with individuals with finer hair and lower densities and certainly lower cross-sectional trichometries. A 70 cross-sectional trichometry is never as good a candidate as somebody with a 90 to 100. And one of the things you'll notice with comparing FUT to FUE is the cross-sectional trichometry in the donor area is minimally effective after a single surgery and even after a second and oftentimes third surgery. But in FUT, there's a significant drop-off in the hair check in the donor area. And the reason is you have to close the margins of those wounds and you put tension in that donor area. And that leads to traction alopecia. So in individuals with FUT, they lose hairs. And what's hair cross-sectional trichometry, hair check? Number and diameter. They don't lose diameter, but they lose numbers. They lose hair follicles. You're killing hair with FUT. And that's why the cross-sectional trichometry drops off the cliff in any patient that undergoes FUT. If you can avoid FUT in your patients, do so. It's a bad surgery. Now, telogen effluvium can be acute, short in duration, or it can be chronic. There's some people that suffer from it for years. For years. So what is the treatment? Number one, remove the offending cause. If they're stressing their life, if they're dieting, if they've been ill, get them well, change their diet, get them over the hump. That will help get their hair back. There are things you can do. Viviscal is useful. PRP. Now, there's a difference in the quality of PRP. There's good PRP and there's bad PRP. Now, we did a study in Istanbul, and I'll get into it, but one of the doctors brought in his PRP kit, and we checked the platelet count on that. The baseline count before we made any PRP was 238,000 platelets per milliliter. His PRP, his platelet count was, I believe, 37,000. That's not PRP. That's platelet poor plasma. And so this doctor was using something that was not of any benefit or not of significant benefit to his patient. PRP should have a higher platelet count than the baseline. Lysine platelets increases the total number of growth factors. The high molecular weight proteins like PDGF and VEGF and TGF-beta. But low molecular weight proteins like IGF will be in equal concentrations regardless of whether you lyse or whether you traditionally activate, and just a little bit lower but close even with not activated PRP. Other things that are growth factor-rich media are amniotic membrane and adipose-derived mesenchymal stem cells, which also supply you with stem cells. And so the adipose-derived mesenchymal stem cells are actually the most potent stimulators of the hair follicle. Exosomes, jury's out on these. I saw a presentation recently that interested me again in amniotic-derived exosomes, but in exosomes derived from bone marrow, I didn't see any influence, and they're very expensive, and they've been taken off the market because the FDA is very concerned about the safety of exosomes. Whey protein, for whatever reason, is useful for your hair. And then, of course, traditional medications, finasteride, minoxidil, dutasteride, latanoprost, and even spironolactone. Topically, these products work better than orally, and you have fewer side effects. So if you can go to a topical, then do it. And one of the things you might want to do is gene test your patient prior to putting them on a long-term protocol, and that'll help you fine-tune the therapy. So if you have more questions or you want to be evaluated or you're a physician that has an interest in this, then feel free to contact me. I'm in New York and Atlanta, and I look forward to hearing from you if you have any questions. And if you don't, hopefully I gave you enough information to where you can make a diagnosis between Telogen Effluvium and androgenic alopecia at least. But bear in mind, too, that the hair check or cross-sectional trichometry is also very good at evaluating hair breakage. You measure the cross-sectional trichometry at the base of the follicle, close to the scalp, and you compare it to the distal end. If there is a fall off between the base and the distal end, it means there's a loss in number, not diameter. So the cross-sectional trichometry will reduce distally. That means hair breakage. What causes hair breakage? Well, everything women do to their hair is bad for their hair. And that includes dyeing their hair, washing their hair, shampooing, swimming, blow drying, curling, straightening, excessive brushing. Everything they do is bad for their hair, and it leads to breakage. Now, men don't have much breakage because they wear shorter hair, but breakage is something that is a clue that, you complain that your hair is not as thick, it doesn't grow as long. Well, you look at the cross-sectional trichometry at the base and distally for hair breakage, and then work with the female to reduce some of the things that are causative, that are weakening the cortex and the cuticle of these hair shafts and causing hair breakage. Hopefully you got a lot out of that. And thanks for listening.
FUE Magazine, the authority on hair restoration surgery.
Educate consumers and help educate doctors.
Into the future.
Let's get started.